Enthesitis in axial spondyloarthritis, axial SpA, and tender points in fibromyalgia FM can overlap in terms of symptoms and locations, leading to potential diagnostic confusion. Here's a breakdown of their similarities and differences. Similarities: 1. Pain and tenderness. Both conditions involve pain and tenderness in specific locations of the body. This can make distinguishing between them challenging, especially since both patients with axial SpA and FM may report widespread pain. 2. Locations. Some common sites of enthesitis and axial SpA overlap with the tender points in FM. For example, enthesitis sites in axial SpA: Achilles tendon, plantar fascia, heel, costosternal junction, chest, greater trochanter, hip, tender points in fibromyalgia, back of the neck, lower cervical, upper chest, second rib, lateral hip, greater trochanter, knees. The greater trochanter, hip, costosternal junction, chest, and lateral epicondyle elbows are locations that are commonly involved in both conditions. 3. Widespread pain. Patients with both axial SpA and FM can experience widespread pain, although the nature and underlying cause of the pain differ. Differences: 1. Pathophysiology. Axial SpA. Enthesitis in axial SpA is due to inflammation at the entheses, the sites where tendons or ligaments insert to bone. This inflammation can lead to localized swelling and structural damage over time. Fibromyalgia. The pain in FM is thought to be due to central sensitization, a heightened response to pain stimuli due to changes in the central nervous system, rather than localized inflammation. 2. Pain pattern. Axial SpA. Enthesitis-related pain in axial SpA tends to be localized to specific sites of inflammation, often associated with stiffness, particularly in the morning. Fibromyalgia. Tender points in FM are distributed more widely and symmetrically across the body, with patients often describing the pain as more diffuse and widespread, rather than localized to specific areas of inflammation. 3. Associated symptoms. Axial SpA. Patients often have other symptoms related to inflammation, such as back pain, particularly in the lower back, joint swelling, and sometimes extra-articular manifestations like uveitis, psoriasis, or inflammatory bowel disease. Fibromyalgia. FM is characterized by a constellation of symptoms beyond pain, including fatigue, sleep disturbances, and cognitive difficulties, often referred to as fibrofog. Clinical implications. Diagnostic considerations. Due to the overlap in pain locations, clinicians must rely on a combination of clinical history, physical examination, and possibly imaging, such as MRI for enthesitis, or laboratory tests, e.g. CRP-ESR, to differentiate between axial SpA and FM. FM lacks specific biomarkers, so its diagnosis is more based on clinical criteria. Treatment approach. Since the underlying mechanisms of pain in axial SpA and FM are different, treatment strategies vary. Axial SpA is typically treated with NSAIDs, biologics, and physical therapy aimed at reducing inflammation and maintaining joint function. FM, on the other hand, is managed with a combination of medications, e.g., antidepressants, anticonvulsants, physical therapy, and cognitive behavioral therapy, focusing on managing central sensitization and improving quality of life. Proper differentiation between these conditions is essential for effective management and ensuring that patients receive the appropriate therapy tailored to their specific diagnosis. It is possible for a patient to have both axial spondyloarthritis, axial SpA, and fibromyalgia, FM, leading to diagnostic and management challenges. This coexistence can complicate the clinical picture, as symptoms from both conditions can overlap and influence each other. Here's how the overlap manifests and its implications. Clinical presentation: 1. Widespread pain and tenderness. A patient with both axial SpA and FM may present with widespread pain and tenderness. The enthesitis pain from axial SpA could coexist with the tender points of FM, making it difficult to determine which condition is primarily responsible for the patient's symptoms. 2. Fatigue and sleep disturbances. FM is characterized by significant fatigue and sleep disturbances. These symptoms can also be present in axial SpA, but are often more pronounced in FM. A patient with both conditions may report severe fatigue, which can be challenging to manage. 3. Morning stiffness. Morning stiffness is a hallmark of axial SpA due to inflammation. but patients with FM can also experience stiffness, particularly after periods of inactivity. Differentiating whether the stiffness is due to inflammatory or non-inflammatory causes requires careful assessment. 4. Central sensitization and inflammation. FM is driven by central sensitization, whereas axial SpA involves peripheral inflammation. In a patient with both conditions, central sensitization may amplify the perception of pain from the inflammatory process in axial SpA, leading to exaggerated pain responses. Diagnostic challenges. 1. Assessment of pain. Clinicians may struggle to determine the primary source of pain, whether it is due to inflammatory enthesitis or central sensitization from FM. This can make it difficult to assess disease activity in axial SpA accurately and to gauge the effectiveness of treatment. 2. Overlap in symptoms. Symptoms like widespread pain, fatigue, and stiffness can be present in both conditions, making it challenging to distinguish between them. Imaging, laboratory tests, e.g. CRP, ESR, and detailed clinical history can help, but may not always provide clear answers. 3. Impact on disease activity scores. Commonly used disease activity indices for axial SpA, such as the Bath Ankylosing Spondylitis Disease Activity Index, BASDI, may be influenced by the presence of FM. Patients with both conditions may report higher disease activity scores due to their FM-related symptoms, which could lead to overtreatment or undertreatment of axial SpA. Management considerations. 1. Tailored treatment approach. Treatment should address both the inflammatory component of axial SpA and the central sensitization seen in FM. This may involve a combination of, for axial SpA, anti-inflammatory medications, e.g. NSAIDs biologics to reduce inflammation. For FM, medications targeting central sensitization, e.g. antidepressants, anticonvulsants, along with non-pharmacological approaches like cognitive behavioral therapy, exercise, and sleep hygiene. 2. Multidisciplinary care. Patients with both conditions may benefit from a multidisciplinary approach involving rheumatologists, pain specialists, physical therapists, and psychologists. This can help address the various aspects of their symptoms, including pain, fatigue, and emotional well-being. 3. Patient education. Educating the patient about the nature of both conditions and how they interact can help in setting realistic expectations for treatment. Patients should understand that while inflammation can be controlled in axial SpA, central sensitization in FM may require a different approach and take longer to manage effectively. 4. Physical activity. Exercise is a key component in managing both axial SpA and FM. However, the type and intensity of exercise may need to be adjusted to prevent exacerbation of FM symptoms, while still addressing the need for mobility and flexibility in axial SpA. Prognosis. Functional impact. The coexistence of axial SpA and FM can lead to a greater overall burden of symptoms, potentially resulting in decreased functional ability and quality of life compared to having either condition alone. Psychological burden. The chronic pain, fatigue, and other symptoms associated with both conditions can contribute to a higher prevalence of anxiety, depression, and emotional distress, requiring integrated psychosocial support. In summary, managing a patient with both axial SpA and fibromyalgia requires a nuanced and holistic approach. Clinicians must carefully balance treatments for inflammation and central sensitization and work closely with patients to optimize their overall well-being. Musculoskeletal ultrasound, MSKUS, plays a valuable role in differentiating between enthesitis in axial spondyloarthritis, axial SpA, and tender points in fibromyalgia M, especially when clinical examination alone is insufficient. Here's how MSKUS can be utilized. 1. Detecting enthesitis in axial SpA, inflammatory changes. MSK ultrasound can directly visualize the structural and inflammatory changes characteristic of enthesitis in axial SpA. These include enthesitis, bony outgrowths at tendon insertion points, thickening of the enthesis due to inflammation, hypoechogenicity, reduced echogenicity of the enthesis, indicative of edema, power Doppler signal, which detects increased blood flow due to inflammation at the enthesis, erosions or calcifications at the bone attachment sites. These findings are typical of active enthesitis and can confirm the presence of inflammation, which is the hallmark of axial SpA. 2. Ruling out inflammation in FM, absence of inflammatory changes. In fibromyalgia, tender points are not associated with localized inflammation or structural damage to the tendons, ligaments, or entheses. MSKUS in patients with FM generally shows normal anatomy at tender points, with no signs of enthesitis, synovitis, inflammation of the synovial membrane, erosions, or bony changes. This lack of detectable inflammation on MSKUS can help rule out enthesitis, supporting a diagnosis of fibromyalgia when tender points are present. 3. Assessing gray areas of symptom overlap. Clarifying ambiguous findings. In cases where clinical examination is inconclusive, e.g., a patient with widespread pain and tenderness that could be attributed to either condition, MSKUS can provide clarity. By identifying or excluding active inflammation at entheses, ultrasound helps distinguish whether the pain originates from enthesitis, axial SpA, or is more likely due to central sensitization without inflammation, FM. 4. Objective evidence for disease activity. Guiding treatment decisions. Ultrasound findings can influence treatment choices. For example, positive ultrasound for enthesitis. Confirmation of enthesitis via MSKUS might prompt more aggressive anti-inflammatory treatment, such as the use of NSAIDs or biologics. Negative ultrasound. If MSKUS shows no evidence of enthesitis or synovitis, it suggests that inflammation is not the primary cause of the patient's pain. This would steer treatment away from anti-inflammatory strategies and toward managing fibromyalgia with therapies targeting central sensitization, e.g., pain modulation, cognitive behavioral therapy. 5. Longitudinal monitoring, tracking treatment response. For patients with confirmed axial SpA and FM, MSKUS can be used to monitor the effectiveness of treatment for enthesitis. A reduction in inflammatory signs, e.g., decreased Doppler signal or resolution of thickening on follow-up ultrasound can indicate a positive response to treatment, helping clinicians assess whether ongoing symptoms might be more related to FM than to active enthesitis. Limitations of MSK ultrasound. Operator dependence. The accuracy and utility of MSKUS depend heavily on the skill and experience of the operator, as well as the quality of the equipment. Limited detection of fibromyalgia. MSKUS is primarily useful for detecting structural and inflammatory changes, which are absent in FM. Thus, while it can rule out inflammatory conditions like axial SpA, it cannot directly diagnose FM. Conclusion: MSK ultrasound serves as a powerful tool for differentiating between enthesitis in axial SpA and tender points in fibromyalgia. It provides objective evidence of inflammation or its absence, aiding in diagnosis, guiding treatment decisions, and improving the accuracy of disease activity assessments. When clinical examination alone is insufficient, ultrasound can be crucial in clarifying the underlying cause of pain and ensuring appropriate management.